therapist in the house? No, but we've got a large number of PA students too, and I've got some really interesting things to share. Can everybody hear me? Yes, okay. There's a really neat grant that came through with PA, and so I'm going to talk about that a little bit. So basically, I'm going to cover some of the hygiene or oral health care issues that we need to be aware of with the elderly. And it's important not only to oral health care providers, but to healthcare providers in general, because many times you will see them before they can even come to a dental office. And they don't come to a dental office because of transportation, cost, additional access barriers. So therefore, it affects all of us, not just oral health care providers. So overall health is important to all, not just to the young or to the old. It's lifespan that we want to be healthy. It also addresses strategies. Health promotion is not just how to improve health, but it's also how to decrease conditions that will cause disease. Now, there are 7 components to health or to wellness. And the concept of this is that if you have health in all of these components, you are considered healthy. We're talking about emotional, environmental, where do people live, what is their housing like, intellectual, how stimulated are they, especially in the elderly. We've learned a lot about dementia. We've learned a lot about these issues these last few days. So we want to stimulate the patients intellectually. Physical, try to keep them as active as possible, try to maintain the activity of our elderlies. And then social, it's important that they interact. You've heard about activity centers, you've heard about different activities when we had the home health agency, nursing home come and talk about the activities that they have there. Spiritual, we've had speakers on that as well, okay? And vocational, many of them, the elderly still want to work. How many times do you go to the grocery store and you see some of them that are baggers, some of them are, Walmart has the elderly, they predominantly hire elderly as the greeters. Okay, so all of these combined are what's considered the components of wellness, okay? So you've heard a lot about the population growth of the elderly. I'm not going to elaborate too much on this, but you can just see the difference between where we're at right now at 34.7 million, a little bit more than that. In 2020, the projection is 53.2 million. Okay, that is a large increase in a large number of elderly. Now again, that was over age 65. This is over age 85 that we're looking at here. And again, just vast increase. Okay, so there's State of Decay was a article and research project that was done by a organization that talked about, and they were assessing what is the oral health condition of the elderly in the United States. This is not a good grade. Would anybody here be happy with a D in any of your classes? This is the grade that was given nationally to the oral health care of the elderly in the United States, okay? And that was due to lack of access to care. It was due to reimbursement issues. Medicare does not cover oral health at all. Now, there are some exceptions, and Dana's going to talk a little bit about that, but in general, they don't. Now, the elderly will lose a large majority of their teeth because of lack of access to care, and what happens is they then, if they don't have the funds to replace their teeth with dentures or partials or more elaborate treatments like implants, they will then not have teeth, right, to chew, which then affects their nutrition, which affects their health. So it's a domino effect, okay? Then you have the shortage of geriatricians. There are not enough dental providers that specialize in gerontology. And there are many things that need to come into consideration there: hospitalization, the medications, etc. Many of them are disabled, many of them are homebound, and then we've got a lot of elderly that are medically compromised. A lot, again, these are issues that you've heard throughout the week. Now, Surgeon General report, Oral Health in America in 2000 is the only Surgeon General report on oral health that we've had in the United States. And it talked about that unacceptable levels of oral disease persist in the most vulnerable populations. And the report emphasized young children, 7 and under, and it emphasized the elderly 65 and older. Now, some of the assessment goals that we should have in geriatrics are to emphasize oral hygiene plans, the elimination of oral pain. We want to make sure that we eliminate as much pain as possible. People don't want to be in pain. Okay? Maximize nutrition for nutritional intake. That's what I was talking about earlier. The healthier someone's mouth is, the better their condition to chew. Okay? Restorations of chewing capacity. And then you also have a lot of weight loss with the elderly. You have weight loss because of many other issues, but again, when someone does not have the capacity for nutrition, you will have weight loss. Decrease ability to swallow, and that could be due to the dryness of the mouth, and that can be, again, caused by medication. Anyone who is on medications for their high blood pressure, medications for allergies, etc., and more complex medications. And then you've got geriatric wasting syndrome. Now, when we do a dental assessment for a geriatric patient, there are several questions that we must ask ourselves. Are they receiving regular oral health care? And the key word here is regular, okay? The other thing we look at is if they do, what does that care consist of? And who provides this oral hygiene care? What is the patient's dexterity level? We learned about rheumatoid arthritis yesterday. What is this patient's dexterity level? What about self-care? How much care are they able to do for themselves? And would an adaptive device enhance patients' ability to maintain their oral health care better? There are different techniques which are called oral physiotherapeutic aids, and some of them can be very simple. You can get a toothbrush, get a tennis ball, put a hole in it, put it at the end of the toothbrush, and now the patient only has to hold the tennis ball instead of gripping the toothbrush. So it's a lot easier for them to hold. There are, you can use the ends of bicycle handlebars. There's a lot of little things that you can come up with when, again, the patient doesn't have to grasp completely for a toothbrush because of the dexterity issues. And that would be like our adaptive device. And how much does the caregiver do? You know, this also entails educating the caregiver so that they can then provide the oral health care for the geriatric patients. And what you wind up having to do is educate the healthcare provider to learn their own health care and how to take care of their mouth so that then they can understand and be able to have a capacity of providing the care for the geriatric patient. Okay? Now, what you find in nursing homes or institutions is that healthcare providers or the individuals who work there, there's usually a high turnover rate, they are underpaid, and so you run into the problem of the maintenance and, again, regular oral hygiene. Are they going to be able to get that? There are so many other things that take priority. Okay? This is an example of someone with, who would definitely have dexterity problems when they utilize their toothbrush. We want to look at management of common challenges. One would be aspiration risk, and Dana Walters, who I'll introduce in a while, will elaborate on that. Oral infections and mouth pain. We've talked about mouth pain. There's a lot of infections caused by the lack of oral health care. Xerostomia, the drawing of the mouth, again caused by different concerns. The dentures, if a denture or partial does not fit well, it's going to cause lesions and sores in someone's mouth. Okay. Rampant decay, a lot of cavities. Again, the inability due to possible dementia. Okay. And then we've got the issue of, does someone know how important oral health care is? Sometimes many patients that aren't elderly don't know or understand the importance of oral health care and the relationship with general health care. There's been a study that people were asked, is your general health, what is the level of your general health? And you could write, it was a Likert scale, and you could say poor, fair, good, excellent. And most of them wrote excellent. And then they said good to excellent. And then they said, what is your oral health care? And most of them were fair to good. So the correlation there is if your oral health is not good to excellent, neither is your general health. But people separate that. And for many times, medical and dental care have been separated, but it's a combination that needs to come together. Okay, this is an example of someone who has xerostonia, and we look at the quality of life. Can you imagine what it would be like to eat and drink with someone, from someone who has a mouth like this? This is burning. This is someone who's, you know, any salts, sweets, anything that's has any acidity, any type of spices are going to really irritate that tongue. You know, think about when you have just a tiny little sore, little aphthous ulcer in your mouth, and how sensitive that can be. Okay, so what are the benefits and cost savings of good oral health care? Well, we're looking at, there's improved quality of life. Okay? The patient will have a healthier mouth. There's reduction in dental emergencies. Many times you wind up having people come to a dental office in an emergency. Many times they wind up going to emergency rooms. Okay? Decreased morbidity because of secondary illnesses that can be caused. There have been cases where patient developed an abscess, let it go for so long that they had to be hospitalized for IV antibiotics. There have unfortunately been some cases where the infection was so advanced that it went into their brain, into their blood system, and there was, you know, the ultimate result was this person, you know, people have died. So you don't think that you can die from decay or from infections in the mouth, but it is, that does occur. Okay? And of course, we've talked about the improved nutrition and hydration. So now you've got a dental team, which can consist of a dentist, hygienist, anybody that provides oral health care assistance, and then you have a caregiver team, which can consist of family members, people that work at different healthcare facilities, home healthcare agencies. And what happens is you have to have a cycle of communication. You have to be able to have, the dental team needs to know what are the functional limitations of the patient. And then the caregiver team needs to learn, you know, they need to be taught by the dental team what can be taught to your patient or what can be done to the elderly. And then there's the cognitive limitations. What can the caregiver and the patient understand? Because think about how many times you talk with a patient, and all of us know a new terminology once we became healthcare providers. And we sometimes tend to speak with a jargon where, like, we can say, you know, these elaborate words about the diagnosis, but, or the treatment or the condition, but do the patients understand? You know, so we need to be able to communicate with the caregivers as well as the patients. Now, one thing that we really have to consider is transportation. Many times there is a lack of transportation and there's difficulty obtaining transportation. And so that, again, is something to really consider. Okay. Okay. These are just some cases of advanced periodontal and decay on elderly patients. You can see all of this is calculus, unhealthy. This is where the gum line should be on somebody's mouth. There's so much tartar or decay, or excuse me, tartar or calculus, that the gum is now way up here. Okay. The same thing here. You see the elongated tooth because of the recession of that gum tissue. Again, this is a very severe case. You should have, this patient's gum line should be approximately here. Okay. You can see from here to here, this is all calculus. This is where the gum is at now. And then this tooth is much higher than the rest because there's recession and the tooth is coming up. So this is a very severe case. And for the frail elderly, oral health care is often not only, again, a matter of oral health, but a matter of medical health for overall health care. And too often, like I said, dentistry has operated in isolation from mainstream health care. Okay. What I want to do next is introduce Ms. Dana Walters. She is one of our master's students in the dental hygiene program, and she's going to talk to you a little bit about her experiences with the institute that you are now participating in, and I will let her talk to you next.
Well, I know how you're feeling right now. I've been in your shoes. You're wanting to eat lunch, and you're counting down how many more speakers there are this afternoon. So I'm going to try not to bore you too much. I was asked to give this talk today because I have been here. And I now work with a doctor in gerontology. We work with nursing home patients, also private pay at-home patients also, but mainly in the nursing homes. I know in the class you heard over and over this week of how the elderly are neglected, forgotten, and abused. After taking this class, I realized my passion for the elderly and how they are neglected, forgotten, and abused. There's a great need for us as professionals to try to take care of these and have an interest in this population. Many times what I find is like Ms. Torre had said, that the caregivers, they are very busy. When you go in the nursing homes, there are the caregivers, the LVNs, CNAs, they're taking care of the whole body. And then when they run into one of the patients that resist, you know, they're hit, they won't open their mouth, and a lot of times the caregivers also don't have the little tricks or know the tricks to have them work with them. And if you look also what we found that, like Ms. Torre had said, that the caregivers themselves, their oral hygiene is not a priority. So why should it make it a priority for their patients? That's where we come into the education part. What we've been trying to do with working with the nursing homes, and like you said also, that the turnover is so great. That one time you go in and you know you have your little caregiver, LVN that you always talk to about a patient, you go in and say, well, where's Helena at today? Well, she's no longer here. So there goes that out the window, and you start all over again. The elderlies that are so often have had strokes, Parkinson's disease, Alzheimer's, and have limited daily function and are susceptible also to aspiration pneumonia. This is aspiration pneumonia is one of the leading causes of death in the nursing facilities. The bacteria found in periodontal disease and the plaque in the oral cavity is the same bacteria that causes aspiration pneumonia. There were 2 studies conducted, one in Japan and one at a veterans hospital here in the United States. They concluded that oral hygiene provided by the professionals, such as dental hygienists, decreased the incidences of aspiration pneumonia. This right here is a picture of a lady, an Alzheimer's patient that they're working on trying to extract. They're going to extract some teeth. She has periodontal disease and a great aspiration risk right here. The geriatric patients also are more likely to develop rampant decay. As we age, our taste buds are not the same. They crave sugar. That's and when they crave sugar, along with the periodontal disease, the xerostomia, and it's just a combination with the poor oral hygiene. It's a breeding ground for the rampant decay. With this background of knowledge, one can see the need for the hygienist in the geriatric setting of the nursing facilities. Since taking the class, I have had the honor of meeting a dentist that specializes in gerontology. With Dr. Dirks, we have developed an oral hygiene program for patients residing in the nursing facilities who are at risk for developing aspiration pneumonia, have xerostomia, and rampant decay. Many people cannot believe that we would want to work in a setting like nursing home facilities. I admit it is hard work, sometimes depressing, but most of the time when you see a smiling face, it is so rewarding. Our goal is to reduce the risk of aspiration pneumonia by reducing the number of harmful bacteria in the mouth. We accomplish this by customizing our oral hygiene treatment for each patient. A bedridden patient on a feeding tube may have an oral debridement on a monthly basis, which includes brushing with chlorhexidine gluconate, using ultrasonic scalers, and then polishing with the chlorhexidine gluconate. In the 6 months that I have been seeing several of these bedridden patients who are at risk for aspiration pneumonia, their plaque index has increased and gingival tissue has greatly improved. Along with the better oral hygiene, the elderly are also more likely to be able to eat better. Finally, customizing the oral hygiene treatment to the patient also allows us to watch for decay so it does not get out of hand, as well as applying the fluoride varnishes on a regular basis. This right here, the picture, I apologize, is kind of blurry. This is a lady I saw this morning before I came over here. This was her teeth after we finished. She wasn't very cooperative. We had to use a mouth block, and it's very difficult to work on them. But as you can see, we made headway here. And I think she's going to feel so much better. She's going to eat better. And she was smiling when she left. That always makes it better. After I'm so mean to them, I just love when they smile. I believe Dr. Dirks and I are doing a great service for the population as far as the oral care, but each and every one of the elderly patients reward us in some way. Whether it be a beautiful smile or a squeeze of the hand, we receive the greatest gift.
And you thought you were ready for lunch and done with me. Just briefly, you have a lot of slides in your book covering different theories and models about health promotion and modification of someone's behavior. I am not going to elaborate too much on that. You have the material. I would encourage you to read it. I know some of you won't. It's up to you. But the transition I want to make here is a little bit about where are the future directions of the elderly as far as health promotion. And there's a lot of myths that we must dispel. It doesn't mean that because you're older, you have this inevitable decline, okay? Or that you're deteriorating fast. Right? We see many elderly that are very active in our lives, okay? People of any age can improve their health if they adopt a healthy lifestyle. Okay? I thought this was really interesting. This is a picture, this was in England, where just like they have school crossing signs and all this, they have this for elderly people near nursing homes and near hospitals. So I thought very conscientious about the elderly, and this was in England. And again, we must focus on prevention, which is critical. And I think all of us as healthcare providers know that prevention is the main target. And let's try to skip here. A lot of the issues are the barriers for health promotion, oral health promotion in particular, are cultural barriers. And this is to make sure people have a difficult time with adapting to the medical society or the medical system, that doesn't take into consideration some of the cultural issues. And what happens is many times the cultural issues are sometimes ridiculed or not taken into consideration. The access to medical care, acceptance of interventions, and health education efforts depend on many factors. Now, some of these points I want to talk about is that elderly minority women are among the most vulnerable in the aged population. And social and political power is diminished in the vulnerable groups. This diminished power is linked with poor health outcomes as well. And these are things that we know pretty much. These have been studies that have been conducted that correlate the social economic status of someone and their health in general. Some of the barriers again, are the aging and the quality of life that we must look at, and the way society is changing in the view of the elderly. Women, again, enter older age poorer than elderly men. And the majority of women over 65 are widowed, and these are things that you've already learned about as far as little social security because of the intermittently job, possibly. The use of prevention by older people is strongly influenced by poverty. So one of the things we want to focus on is that it's important that we honor and respect and encourage independence as long as possible. Autonomy, honor, and respect. And how many times do we need to think about our own autonomy? You know, we all want to be respected and we all want to have our wishes honored. Well, the elderly are just the same, okay? I think the most important thing here is autonomy. You know, none of us want to have somebody do everything for us. So the more that we can encourage the elderly to be able to function and maintain their lifestyle, the better we will be as healthcare providers. And many times as healthcare providers, it's very easy for us to say, oh, they're already old, they're going to lose their tooth, it's okay, or, oh, well, you know, I don't have to spend as much time with them. But, you know, this is in any profession. We need to consider that we must honor and respect them because they are the patient that has come to see you and has trusted you and has put their health in your hands. Okay. We would think that retirement is just relaxing and having fun, but I beg to differ. I think retirement should be living life, enjoying it, and getting out there and moving around. Now, the study I wanted to tell you, or the grant that was received by the PA program here at the Health Science Center, is one that entailed providing PA students with the general information of oral health, implementing that. And I don't know if any of you, have you already gone through that? Can you see, what year are you in? Going into second? Yeah. Because it was just developed, I'm not sure if it'll be implemented or you'll learn it then before you graduate. But what was developed is with two of our faculty was that we wanted PAs to learn what they need to look at when they have a patient, what they need to look at in their mouth. Many times you will see them a lot more than we will, or healthcare providers, because of some of the things I talked about. Dental health is not always a priority or can be implemented, or they can come as often, or there's cost, but you will be seeing them for many other ailments. So if you can look in their mouth, you're going to say, look in their throat, right? And how many times do nurses and physicians and PA say, you know, ah, you have the patient say, ah, and you look in their mouth. But we're asking to not just look through the mouth and straight to the throat. We're asking that as you're doing that, you look at the mouth and the teeth and the tissues. And that's what this grant was proposing, that PAs will be trained for that and they will be able to apply that knowledge, which I think will be a wonderful, wonderful idea. Because like I said, they're going to be seeing you more than they would see a normal healthcare provider. Okay, so it has been said that the mark of a great community is how well it cares for its most vulnerable citizens. In this case, we are talking about the elderly. And some of us provide care for our own parents and loved ones, and the others of us are coming into grips with our own inevitable aging process. Are there any questions, comments, thoughts? Yes.
Being that like normal salivary function is muscarinic M3 receptor mediated, do you find that type 3-5 xerostomia is more like common in elderly, or is it a 1-2 as well?
It's all of the above. I think that there's a lot of factors that come into that, but we do see it a lot more in the elderly with three.
Okay.
Yes.
This grant you were talking about for the PAs here, is that part of it like a national trend, or is that just something isolated?
The grant was only given here at the Health Science Center. And so PA students are really, really knowledgeable, or will be able to have that in their curriculum. But it's something that hopefully will be duplicated and can be carried on to other universities or trainings. Anybody else? No, that's it. Yes, ma'am.
Is this the Dr. Dirk, is that who you said you work with?
Yes,
Is he one of the only ones working with this population? Is that what you meant?
It's Sarah Dirks. She used to be affiliated, well, she still is affiliated with the school, but she was the geriatrics here. As far as I know, there's only one other dentist in San Antonio that works with the geriatrics, besides
so
her.
You go to the location to...
Many times we have an office right across the street that we work. All the patients that we can see that can come out of the facility, we see at the office. But I go on site 2 or 3 times a month to certain facilities. I actually have a patient this afternoon at one that has not, she is 46, mentally handicapped, does not leave her bed, does not leave her room, but she's coming to the office, and she hasn't been out of her bed or facility in several years. but we need x-rays on her. We have a portable x-ray machine, but they're going to bring her in on a gurney.
Yes?
About dentures, do you want your patients to have their real teeth as long as possible? Or
Absolutely.
Like it's in the slide, if there are messed up that bad, do you end up trying to persuade them to get dentures right away, or?
The goal of prevention is to maintain everybody's teeth as long as possible, okay? Sometimes the periodontal disease, and it's usually periodontal disease in the elderly, is so advanced that you do need to extract teeth for them to be healthy, because the infection, you don't want that to spread to other areas in their mouth or their body. So you try to save the teeth, but sometimes we have to extract teeth. And in that case, we do want to encourage the dentures or the partials, because then again, their mouth will be functional and so will their mastication. Okay? But a lot of issues with dentures and partials in the elderly is the fit. They have to be able to fit properly, and it's very challenging to take correct impressions, for them to sit still. Again, the serostomia, the saliva, all of these things come into play. So it requires a lot of adjustments to make sure that they fit properly. You have to do a lot of adjustments on somebody who's not elderly, and so the elderly even much more so.
Is there a certain age that you kind of stop with dentures, or do you?
No, any age. Any age. Anybody else? Yes? Exactly, and that's one of the things that we are really trying to, the oral health community is trying to do something about. For years, there's been things going up to legislators to try to see if Medicare will cover something. You would think that Medicare or Medicaid would cover, some type. Now, Medicare does to some capacity. Medicaid covers nothing to nursing homes, to people that are institutionalized.
Medicaid will cover
Right.
if they're 1263s.
So do you want to explain what 1263?
1263, they will cover if it's medically necessary on Medicaid, and if they're not a full vendor Medicaid. And that means if they supplement every month, if they're in a nursing home, Medicaid pays and Social Security pays for the nursing home. But if they're not a full vendor, which means they have a supplement from their other income from before, they will pay for treatment. As long as it's done within a 3-month period, I believe.
And the nursing home is required to provide overall health, and that's when that came into play. But there are still we're way behind in a lot of that. It's underutilized. The other thing that we're trying to do is it went up to legislature this year, and it's still there. It hasn't come to vote yet. And that's to see if dental hygienists can legally practice in different settings besides without general supervision, so that you can go in and do own care and do dental hygiene assessments. And then, you're still working with a dentist, but it's not required that they're there together. No, that's still up for a vote. We'll see what Austin tells us.
And from what I've got from Austin and how I am able to go in the nursing home without Dr. Dirks is we have a treatment plan, and as long as she has she does an exam at least once a year, just like in the dental office for a hygienist. And we have a treatment plan for each patient for each month, every 3 months or whatever we've customized for that patient. I'm able to carry that out with her supervision.
Any other questions? Thoughts? Well, thank you so much for your attention.